colorectal cancer. Objectives similar to what we talked about with prostate. We're going to look at the background, colorectal cancer, treatment options, and talk about some targeted therapies in colorectal cancer. Etiology and patho. Colorectal cancer basically starts from the colon or the rectum. These cancers can also be called colon cancer, rectal cancer, depending on where they start, right? But collectively, we just say colorectal cancer. Okay, colon and rectal cancer, they're often grouped together, but there are several, they are kind of different because they have specific features like that. When you look at the organ itself, the colon and rectum make up the large intestine, which is all part of the digestive system. So you all can already think about what this would mean, right? We talk about prostate, talk about urinal, erectile dysfunction, yada, 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 because of the location of the organ. But in this case, we're talking about something related to the GI system. So you can think about the side effect or the presenting signs and symptoms that the patient will show up with initially. All right, most colon cancer starts as a growth in the inner lining of the colon or the rectum, and these growths are typically called polyps. So that's usually how it starts. They start out as polyps. Most colorectal cancers are adenocarcinoma, so that's the type, that's the histologic feature of the cell in the colon or rectal cancer. Now let's look at the numbers. I know with prostate I showed you a different number scheme, but here I'm showing you this purposefully. And as you can see, for male and female, either new cases or mortality, colon and rectal cancer remains, number three. So this is also another serious type of disease that you guys will also probably see in your practice. Okay, so you see right around 9%, 8% of all estimated cancer cases in the United States for this year. Risk factors. Genetics is pretty significant for colorectal cancer. There is this called Lynch syndrome, and I know I mentioned it briefly with prostate cancer, but Lynch syndrome is also known as hereditary non-polycystic colorectal cancer, HNPCC. And this is responsible for about 3% of all types of cancers. In this case, most patients will not have excessive amounts of polyps, but there is just a genetic abnormality that predisposes patients with Lynch syndrome to develop colon cancer. The other genetic risk factor is called FAP, familial adenomatous polyposis. In this case, there's going to be thousands of polyps in the inner lining of the colon. So you can consult Dr. Google. Dr. Google, just put it, Google. FAP pictures. You're going to see the lining of the colon with thousands of polyps. So that is significant in FAP. But with Lynch syndrome, you wouldn't see a whole lot of polyps. However, both of them are very high risk for turning into colon cancer. Lifestyle-wise, being overweight or obese, physical inactivity, eating diet that has high red meat and processed food. Processed meat, jerky beef. You all eat jerky beef? I used to eat that when I was a technician. I was like, jerky beef and Coke. I think I count by 5. Anyway. And then alcohol and smoking, okay? Race, African American again. We see African American coming up again, being one of those disadvantaged races when it comes to colon cancer. Also, those that are from the Ashkenazi Jewish population, they are at risk for developing colon cancer. Family history of colon cancer, or those that have FAP, then those that have inflammatory bowel disease. You all know what inflammatory bowel diseases are? What are they? Crohn's. Ulcerative colitis, yes. So those two, if you have patients that have Crohn's or ulcerative colitis, they are at a greater risk for developing colorectal cancer. Of course, older age. As patients go older, the risk increases. Prevention strategies, nothing has really been said definitively. The same thing for prostate as well. Colon cancer, prostate cancer, nothing much has been said or FDA approved to prevent or reduce the risk. I mean, there are talks about aspirin, cyclooxygenase inhibition, different things here and there. All right, let's talk about the signs and symptoms, things that you would think about, right? Because it impacts the GI. So you're looking at changes in bowel movement, you're looking at blood, bleeding from the anus, blood in the stool, abdominal pain, loss of appetite, and because of inability to digest food properly, patient will start losing weight. Okay, weight loss is also another one that you will see. Then most of the time they would also become pale because of the location of the disease. Another thing that you can also notice is called change in the stool caliber. Normally there is an expected diameter or the size of the stool for an adult. But when a patient starts telling you the stool looks pencil-like, pencil thin, right? That probably tells you that there's an obstruction. Something is obstructing it and making it thin compared to the normal size of the rectal capacity. So those are some of the things that you will hear with this type of disease. All right, screening is also another important thing to talk about. Again, I'm going to focus in on the NCCN guideline. Some of the information included is for completeness because there are so many guidelines, all available. But for the most part, average risk patients, okay? That's where you focus your attention on. Average risk patients, you want to do colonoscopy every 10 years. That's the gold standard. I'm going to talk about that in the next slide. There are other options, fecal blood tests, DNA tests, the Cologuard, all these other things that are possible options to use, but colonoscopy every 10 years for an average risk patient. Patients that are at increased risk, IBS, because of Crohn's disease, ulcerative colitis, then you want to screen them earlier on in life, okay? And you repeat their screening pretty quickly, every 1 to 3 years. Okay, if a patient has FAP, because their entire colon will be covered with polyps, so you want to screen those people early and sooner as well. Okay, then patients that have high risk, patients because of family history, then you want to screen those people at a younger age, some of them even as early as 40 or younger, depending on when the family was diagnosed with colon cancer. Lynch syndrome patients, I said earlier, with Lynch syndrome population, you wouldn't see a lot of polyps, but even if it's 1 or 2 polyps, they transition quickly to becoming cancerous. Okay? So because of that rather quick transition to cancer in the colon, for Lynch patients, you want to start screening at a young age of 20. Okay? Compared to general population of 40, 45. So patients that have Lynch syndrome, you start screening them at the age of 20 or 25. And to be honest, I've even seen patients do a complete colectomy, meaning they remove the entire colon just to preserve their life, even before they get diagnosed. Because at some point, a patient that has Lynch syndrome, it's almost given that they will develop colon cancer. So if they get their entire colon removed, then they would remain on TPN. Dr. Matthews taught you guys TPN, right? Yeah, so those folks will just be on TPN for the rest of their lives. Dr. Matthews taught me too, so that's cool that she's still around. Yeah, several years ago. Okay, other screening modalities, we're looking at, fecal occult blood test, because normally the stool should not have blood, right? And sometimes you call it occult because it's not something you can see, it's not visible. So with the fecal occult blood test, we're doing a test in the laboratory to determine if the stool contains blood. And if there is blood physically, blood can present as either bright red blood in the stool or dark tarry stool. All that tells you is basically the location of the bleeding. You have something to share with the class, ladies? No. Thank you. So if the stool appears to be dark tarry, that tells you that the bleeding is occurring in the upper GI tract. And because of oxidation and everything else, by the time it comes out, it is dark tarry. But if it's bright red blood, that means it's occurring in the lower GI, so after a bowel movement, it's going to appear as bright red. So that can kind of tell you, is it more of a rectal cancer or is it more of an upper GI or upper colon cancer if the patient eventually gets diagnosed. Colorectal is another one. I don't know if you guys watch TV ads sometimes. You see the little box singing, dancing, jumping in the body. If you guys have time to watch TV. But that's the one, colorectal. You basically get your stool samples, ship it off to a lab, and they do the test. They share that information back to your provider. Okay, we're going to talk about colonoscopy. Colonoscopy is essentially, as shown in this picture, that's the gold standard. And you basically put a camera through the colon, entryway is through the rectum, and go all the way. And I'm sure for those that work in retail, you've sold those 1 4-liter drinks, right? That patients have to use to clean out their GI tract, because you want the GI tract to be as clean as possible so that you can visualize, or the people doing the colonoscopy can visualize the inner lining of the colon. The good thing is if they identify polyps while they are doing a colonoscopy, they will clip and take a biopsy and take it to the lab to evaluate. Is it benign? Is it something that is concerning? If everything comes out clear, then you repeat it again in 10 years. Okay? Questions, comments? We're good? All right. Okay, so staging. When we look at staging, pretty much the same thing. T for tumor, N for node, M for what? Metastasis. That does not change. And again, I've included pictures for those that are pictorial or visual learners. Natural history of the disease, like we can all imagine, right? If the disease is localized, then the survival rate is better. If it's a distant disease, the survival rate decreases. So, early detection does what? Saves lives. Yeah. So, Christine and Andrew, both of them are interns in my breast cancer project, and every time, we create flyers, early detection saves lives. It does, not just in breast, in colon, in prostate, everywhere you go. Early detection really saves lives. All right, let's talk about treatment. This slide is very busy. I know, looks scary, looks like a branching tree, but that is what the real NCCN guideline looks like. My goal is to break it down and help you guys make sense of what all these branches mean. Well, feel free to look at it, for as many that would like to join, come over to my end of oncology practice. We will have fun talking about this, as you go through your programs. Essentially, the first treatment option, depending on the type, is going to be surgery. So this is the treatment choice in patients that have curable disease, right? If the disease is still localized, it has not extended out or something, then you want to cure them by removing the tumor from the colon. Or you can also use it for palliation. Imagine there is a huge tumor in the colon and the person cannot defecate, they have to strain, they are always passing out pencil-like forward movements. That's not convenient, right? So sometimes you have to, even though it's not curable intent, you still have to surgically take out the disease from the site of the colon. And usually with colon cancer, there is going to be an area of 12 lymph nodes that needs to be taken out concurrently, just to make sure that the lymph nodes have not been impacted. Okay, so here again we have pictures just so you can see surgical approach here. You can either do complete resection of the tumor and any lymph node that is in its surrounding. You could either combine or close it up. That's the first picture showing anastomosis. This first one right here. Oh, well, you guys can't even see my head. Okay. But you see what I'm talking about, right? The very first picture is talking of removing the cancer and then closing it back up. That's anastomosis. Depending on how much is removed, depending on the location, a patient might be able to do anastomosis, but if they can't, then they would have to get a bag. In that case, instead of having fecal deposits, like we would all go to the restroom, a patient that has a bag, the fecal deposit will go into this bag, basically. And when they go to the restroom, they empty out the bag and replace it with a new one. So that's their own process of using the restroom in this case. And believe me, there are several patients like that. It's really nice and pretty. They wrap it around, they have body wraps, and just wear appropriate clothing to get it all covered up. And you don't know what people have under their suits sometimes. Okay, surgical treatment now when you look at rectal cancer, because the rectum is located closer to the anal wall, right, to the anal opening, and there is something in particular about the anal opening because it controls, there's a muscle there that controls defecation, right? So if the rectal cancer is too close to the wall, then it can impact the ability to control if you want to go or if you cannot go. So that's something to be very mindful of. Depending on the location, they try to preserve the function of the anal sphincter. That's the muscle that controls the opening and closure when we go to defecate in the restroom, basically. So that's what this is all showing. The next option now is, okay, the patient doesn't want to do surgery, or they are older, different, whatever the situation might be, they can actually have stent placement. Okay, so as you can see in this picture, the disease is there, where you put a stent and you expand the wall. At the end of the day, you are trying to reinitiate that opening by placing a stent so that way there is an open space for fecal material to go through. Okay, questions, comments on surgical approach before we talk about radiation?
Does the stent have to be replaced or it stays there?
In the stent, sometimes it can be replaced if it gets, sometimes it gets displaced. So if it becomes displaced or dislodged, then they have to go in and replace it. But for the most part, it will be permanent. Usually it's more for like short-term relief, right? If you know the patient is not going to be around for too long, or they are elderly patients, and you're just trying to get them every patient has their goals. So I want to see my grandbaby's graduation, wedding, whatever, just keep it till whatever date, type of a thing.
Yes. So cancer cells can grow.
I'm sorry?
Cancer cells can grow at this case.
Into the
Continue to
stent?
grow.
Yeah, because you have not removed
Yeah.
cancer. Yeah. So the cancer is still intact. You see? The cancer is still there. They've not taken it out. And even when you take out the cancer, physically, there is still the micro particles that you cannot see. So there are cases when you go in and remove the cancer, you still have to give them chemotherapy. So that way that chemotherapy can kill off anything that you cannot see physically in certain cases. Does that make sense? All right. Radiation treatment, similar to what we talked about with prostate cancer. In this case, radiation is not very used as a mainstay, but sometimes it's just to palliate. You know, maybe the tumor can be bleeding sometimes. You have some tumors that are very angry and bleeding out, and you want to stop that bleeding. So you apply radiation therapy in such cases. Acute toxicity, cramping, there can be, GI discomfort, nausea, vomiting, and then there can also be diarrhea from a long term, especially depending on the location of the disease. Then, depending on the location, we just try to visualize the colon, right? There are so many organs surrounding the colon. So because of all these organs surrounding the colon, all the other organs can also be impacted because of the radiation treatment. So urinary incontinence, bladder, inflammation, things of that nature. Okay, again, we are back to this slide. I'm bringing it back up again because chemotherapy, in this case that we're going to talk about, are the general cytotoxic chemotherapy agents. Okay? There are a few targeted options that I will talk about later, but for the most part, when you look at the treatment options for colon cancer, is going to be, cytotoxic chemotherapy agents for the treatment of colon cancer. The same BSA calculation remains, so please commit this to memory because we will have some calculation questions that you guys will be responsible for. And I do have a couple of work examples or cases that we will discuss today in the next 10 minutes or so. So, Mosella equation as well as the Du Bois equation. And keep in mind, I've had a student ask me before, the square root covers everything, okay? The 36, so it's height times weight, height in centimeters, weight in kilograms divided by 3600, square root of everything. Okay, I've had a student that said the square root was only for the upper portion and not the 3600. So please keep that in mind. All right, any questions, comments before we move into some chemotherapy regimens? We good? All right, okay. So here are the most common, and I say most common because there are several options, but I've just included the most common that you will probably see depending on where you practice or in your NAPLEX exam, okay? The first one is called FOLFOX. I've included the frequency, I've included what the patient will receive on day one. Typically with this, the first day they will receive 5-fluorouracil, 5-FU, 5-fluorouracil. They will get a bolus dose, that means, immediate push, 400 milligrams per meter squared. You give that along with leucovorin. I'm going to talk about leucovorin soon. Then they also get oxaliplatin on the first day. Subsequently, they would now receive the same 5-fluorouracil over a 48-hour period, continuous infusion. So the patient will come into the clinic, receive 5-fluorouracil, leucovorin, oxaliplatin. Then they will go home with a pump, a little pump that has a cassette which will infuse the chemotherapy over a 46-hour period. Then they come back after 46 to 48 hours to detach the pump from them. So they still go to work, they go to the bank, they go to the grocery store, they pick up their children, they still live a normal life, like most people will. CAPOX is an acronym for a combination medication which includes oxaliplatin and capecitabine. Capecitabine is an oral medication, and I believe I have 1 or 2 slides on that as well. So capecitabine is oral, they will take that for 14 days. get oxaliplatin for 1 day, but the entire cycle is 21 days. Fulfirinox, the main thing I'm going to focus on are the drug components itself. Okay? I would not expect you guys to know the dose. I don't expect you to know the frequency, but the drug components, what's 5-FU, what are the common toxicities of 5-fluorouracil, or irinotecan, or oxaliplatin. Okay? All right, so we're going to talk briefly about 5-fluorouracil. It inhibits DNA synthesis, and it's a more toxic pathway for rapidly dividing cells. Remember, intravenous or cytotoxic chemotherapy for the most part are designed against rapidly dividing cells. So, 5-fluorouracil comes in two major formulations. There is the intravenous formulation called 5-FU. That's what we call it, 5-FU. And there is the oral formulation called, brand name is Xeloda. Generic name, capecitabine. Okay, so please note that. Brand name is Xeloda, generic name capecitabine, and that's an oral formulation. This is about the only drug where you have IV and oral. Most chemotherapies are IV only, oral only. But 5-fluorouracil is one of those where you have both IV and oral formulations, so don't get it confused. And I've included some pathway pictures here. 5-fluorouracil has several indications, but I'm just narrowing it down for the purpose of colon cancer discussion, and knowing that because it's very common, you might come across it in your labels. Capecitabine, on the other hand, also has a lot of indications. It's oral formulation, you take it by mouth, and this has its own dosing. Again, I'm not going to ask you about dosing, please keep that out of your mind. Common side effects, this is what you should know. This is what I would expect you to know. Okay, mucositis. Mucositis meaning blisters in the mouth. And it makes sense because it's working against what? Rapidly dividing cells. So patients can end up having blisters in the mouth. They can have hand-foot syndrome, blisters, discomfort, irritation in the palm of the hands and in the sole of the feet. Nausea, vomiting, as well as diarrhea. The skin tone can change and also have bone marrow suppression. Do you all know what bone marrow suppression is?
Yes.
Okay. So red blood cell, white blood cell, platelets, everything decreases because of this drug working against what? Rapidly dividing cells. So that's, if you understand that basics, it would help you make sense of all of this. Leucovorin in this case, okay, I'm going to emphasize, leucovorin in this case enhances the toxicity of 5-fluorouracil. Okay, so leucovorin, I'll come to you. Leucovorin enhances the toxicity of 5-fluorouracil because you have to use it along with Folfox, Folfiri, Folfoxiri. See, this here, I put 4 regimens, but 3 out of those 4 have leucovorin in it. Leucovorin is not a chemo drug. It works to enhance, it's an enhancer. See that in this situation. There are other uses for leucovorin that I'm not going to go into for this class, but for the purpose of this, just know that leucovorin is an enhancement to the toxic effect of 5-fluorouracil. Question?
Yeah, for the mucositis,
Mm-hmm.
mucositis, is there any like a treatments to help with that if patients on that 5-FU?
Mm-hmm. Yeah. So usually we use the magic mouthwash. Yes. Are you guys familiar with the magic mouthwash? The triple mix? Retail folks? Yes. So we do magic mouthwash, and I do that pretty often on my own end of clinic because it just helps the cold and soothe so they can eat, right? So imagine you already have colon cancer, you already cut part of the colon, you're taking this toxic drug, now you can't swallow stuff, so magic mouthwash helps. If that does not help, there are other things that can be done. First line, magic mouthwash. Make sense? All right. So that's that's about it for FISFU. The next drug I'm going to talk about is oxaliplatin. Okay, I'm including these pictures and mechanism of action here for completion. The same slide that I used for you guys in your P1 year. Specifically, what I need you to pay attention to is that oxaliplatin causes cold sensitivity. Okay, so when a patient gets oxaliplatin, the first 3 days or so, they get very sensitive to cold. Simple things like, hey, grabbing a gallon of milk from the fridge and feel like they're getting a shock. It's a type of neuropathy because one of the side effects of this drug is it affects autonomic nervous system. Okay, so they have cold sensitivity. Ice cream, no, you can't do that because it's like a shock sensation. If anybody in Alaska, Canada, snow zone ends up being on oxaliplatin, the first few days will be very, very tough because of the weather and how cold it gets. So that's something that you guys should pay attention to. Other thing with irinotecan, the drug class here is what? It's a topoisomerase inhibitor. Again, very blind cytotoxic agents, right? That just kills everything. And with this, do anybody remember the main side effect for irinotecan? No? You think so? Immune suppression? Okay, yeah, it can cause immune suppression. Anyone remember? I run to the can. Yeah. You remember now. So irinotecan, that's the name of the drug. But one main toxicity is it's known to increase secretion. So we just call it I run to the can, meaning you gotta go to the point. You're sweating, you're having hypersalivation, you have to use the restroom, you have to pee, everything is just cholinergic. It's that push that happens. So one of the main side effects is acute and delayed onset of diarrhea, along with salivation, sweating, urination, almost on the spot. So because of that, we use atropine. What's atropine? What drug class is atropine? Anticholinergic. Perfect. You got it. So it makes sense. Irinotecan stimulates the cholinergic pathway. You use anticholinergic to suppress that side effect. So we always have an atropine on standby whenever patients are receiving irinotecan. Otherwise, they can have diarrhea in themselves on the chair where they're sitting because they can't control it. Okay. Also, loperamide. You all know loperamide, right? Okay. That's also another one that we use often. So these are things that I want you to pay attention to because side effects. That's where we come. That's where you see us. That's why we're pharmacists. The patient can be on this medication and swing by your pharmacist to ask you questions. Hey, what can I use? It's a Sunday, it's a Saturday. The clinic is not open. But at least you can help provide some information in this regards. All right, outside of the chemotherapy that I've talked about, bevacizumab is also another agent that we see used often. And bevacizumab is basically a vascular endothelial growth factor inhibitor. So it inhibits the vascular endothelial growth factor. And let me kind of explain this. Look at a cancer cell like a baby, an embryo that is being grown. When you are growing a baby or an embryo, you need blood vessels to feed that cell, right? So natural mechanism, the way our body is designed, is to stimulate blood vessel formation, to get blood into that tumor, into that baby, into whatever it is that is growing rapidly. So bevacizumab, the way it works is that it works against blood vessel formation. Does that make sense? So, when you have rapidly dividing cell, be it a baby, be it a cancer, be it a tumor, blood vessels are being produced because our body are designed to grow things. But in this case, it's unfortunate, it's cancer. So this drug is designed to work against that pathway of blood vessel formation. So it's called an anti-angiogenesis agent. Angiogenesis means you are producing blood vessels. Anti, you're working against that process. So that's the all the picture, all of this. Summarize, that's how I would summarize it. So bevacizumab has a lot of indications besides colon cancer. As you can imagine, actually not almost, every cancer requires blood vessel formation, right? Unless if it's a cancer within the bone marrow itself. So it has numerous indications, including colon cancer. In this case, if a patient has metastatic colon cancer, bevacizumab is one that you would want to use upfront. And like you can imagine, because it's working against blood vessel formation, there are certain side effects that will come with it. These side effects are things like hypertension, right? Hypertension affects the blood vessels, right?
Yes.
It's a vascular related disease. How about blood clot? Does it make sense too? Okay. How about bleeding? Does it make sense?
Yes.
Yeah. So again, it's a lot of alphabet soup at this point, but I'm trying to hopefully help you make sense that when you go back to read, you can tie it all together. My goal is for you to understand. I prefer understanding over cramming. Cramming has its place, but understanding is the core. When you understand, it makes it easy to recall, and I don't have to. On NAPLEX Day, when you see a question like this, boom, make sure you get it 100%, okay? All right, these are other agents that I really won't spend too much time on. I don't want to overwhelm you guys, but just know that there are other opportunities to give targeted treatment when it comes to colon cancer medications. And their pathway are pretty cool, very interesting pathways. Then there are also oral medications that are available. I actually recently published a few months ago, maybe 2 months ago, on combination of regorafenib, this regorafenib right here, which is an oral agent with 5-fluorouracil. So myself and one of my physicians, oncologists at Methodist, we started, using that combination on a few patients, and they're having pretty cool results. And that's already published. Yes, question?
Yeah, this maybe a little bit on the side, but there was, back in June, there was a recent research on a drug that was like 100% clear on rectal cancer.
What cancer?
Rectal.
Rectal?
Yeah, it's called Dostarlimab, and I heard it's recently approved for like, in January, they approved it for rectal cancer. It was like for advanced, current standards of treatment care. Like, do you have any information on that?
I'm not including that purposefully, because for your NAPLEX, right? Remember I told you I'm not going to make you oncology pharmacist in 2 hours. NAPLEX will focus on your most common drugs. NAPLEX is going to focus on your most common concepts. So my goal is to teach you those most common drugs, those most common contexts or concepts, right? So that then, when you come to my side, if you are on rotation with me, we talk about those first lines. We review all the journals. If you are a resident, of course, we do journal clubs. We do clinical trials. You understand what I'm saying?
Yeah, no, I'm just asking about your opinion on that.
Yeah, we can talk more about it later, but for the purpose of everyone else, we just keep it within everyone's knowledge base. It's a broad audience. Make sense? Right? Do you guys want me to lose you when I get into the weeds? Let's keep it simple. It's complex. Well, good points. Yeah. All right, that's pretty much wrapping it up with colon cancer. Concepts, understanding, that's my goal. I'm going to walk through a few cases, maybe 1 or 2. We have about 10 minutes. And I want you guys to engage because you're gonna see similar concepts in your, whenever I think you have an exam in, I don't know, 2-3 weeks or so. So we have this case. SY is a 58-year-old male diagnosed with metastatic colon cancer. We have the height, we have the weight. The oncologist is recommending Folfox. Folfox is one of those drugs, one of the 4 that I talked about earlier, with bevacizumab. This is the dose for the patient on day 1. Day 2 is here, and supportive care medicine. Like I said, if I'm going to ask you any question on chemotherapy, I will include the dose. At least this level of dose, the basic dose. Then you have to calculate the actual dose for the patient. So I won't expect you to recall what's the milligram per meter squared of 5-fluorouracil. I will give you 400, but you have to now calculate the actual dose for the patient. All right, so we have questions. What is the BSA for patient SY? Okay, pull up your calculators. Let's do a quick walkthrough. What's the BSA for patient SY? Okay, height is 5'7", weight is 194. Okay, draw the answer when you have it. And we are using Mosella equation. Anyone? And I will post this after class, okay? I will post the case and the answers at the end of class. Anyone? We have several questions. You got it? 3.02. Okay, another option, another attempt. Thank you for trying. 2.03, another trial. 2.04. Okay, another person. Did you round? The answer should be 2.04. Okay, watch your roundings, because be very careful of that. Okay? And BSA is expected to be given in 2 decimal places, okay? When I ask you the question in your exam, I will require you to put the answer in 2 decimal places. This is not going to be an option, it's not going to be ABCD. You have to type in the exam soft, you have to type it in yourselves. Okay? And when you're typing in your response, make sure you type in 2 decimal places. All right, so the BSA is 2.04. What dose should the patient receive in milligrams in the nearest whole number for oxaliplatin after 3 cycles? Okay, I'm going to repeat the question. What dose should the patient receive after 3 cycles for oxaliplatin? Okay? So patient is getting 85 milligrams per meter squared per cycle. We have calculated the BSA to be 2.04, right? So what dose will he receive after the first cycle? Do you get it? So it will be 85 times the BSA.
173.4.
Okay, but now after 3 cycles, what will it be?
560.
Okay, BSA is 2.04. Patient is receiving 85 milligrams per cycle. So after 3 cycles, what will it be? 520.
Yeah.
Okay, good. Did I lose anybody on that? Okay. All right, so the same dose, and these are the type of dosing questions that I would ask. I'm not gonna ask you the one that you can cram, right? But this one you have to walk through to get it, okay? What dose in the nearest whole number, and keep in mind, am I saying whole number, is it in decimal places, yada, 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 of the bolus 5-fluorouracil will he receive with his first cycle? Okay, so I will go back. He's getting 400 milligrams per meter squared bolus. So what will his first dose be? 5-fluorouracil bolus dose.
How do you apply for cycles?
Hold on a second. Everyone put on that. 2.04 times 400. So yeah. Okay. What was your question?
How do you apply for cycle?
How-
Meaning is the first cycle they calculated those, we use that one, and 3 cycles, we just multiply by 3.
By 3, yes. So my question is, how do you calculate for 3 cycles, 4 cycles? You basically calculate for 1 cycle and multiply by 3, if I say 3 cycles. If it's 4, you multiply by 4. If it's 1 cycle, then by 1. Okay? Then, similar question, what dose in milligrams and grams? Okay? Think about that, milligrams and grams. Will is 5-fluorouracil continuous infusion be? Okay, so I'm gonna go back. Is getting 1,200 per meter squared per day times 2. This is a bit complex. I'm warning. So BSA is 2.04. How much continuous infusion 5-FU will you receive?
2,000 in milligram or
In milligrams and grams.
2,448. Then 2.44 grams.
So keep in mind that it's getting this continuous infusion for 2 days.
For 2 days.
So 4,896.
4,896.
Yeah. Did everyone follow? Okay, so 1,200 times BSA of 2.04 times 2, and that's in milligrams. Then you round up to grams, so about 5 grams per cycle. All right, so now bevacizumab. Oh, sorry, I thought I was showing that already. The next question is, what dose of bevacizumab will he receive after 4 cycles? Okay, let's backtrack a little bit and go back to the case. Patient is receiving 15 milligrams per kilogram.
Is that 5?
I'm sorry, 5, sorry about that, yeah. 5 milligrams per kilogram. And he weighs 194 pounds. So you have to convert from pounds to kilograms. And then multiply your kilograms by 5 mg per kg. Then you multiply that by 4. I can hear that. 4. Mm-hmm.
And 4,441.
4041. Is that what you're saying? Okay? Anyone else? If you don't get this, you're gonna, for 4 cycles. So multiply that by 4. Okay, again, I'm going to post this. I'm going to post this case with these answers on Blackboard. Take your time, walk through it. If it's too much pressure right now, it's been a long morning, I get it. Please make sure you understand. If you don't, send me an email. Okay? Okay, so send me an email and I'll be happy to walk you through it again because you're going to see a similar concept. Okay? It's all about concept in your upcoming exam, and I'm very sure in Naples you will see concepts. Okay? It's going to be, it won't be exact, or maybe it's going to be exact, I don't know. I don't have the exams written yet. But you'll see similar concepts. Okay? All right. Let's move on. It's 11:01. I promise I won't stand between your lunch. But I have one more case. Same patient, but now is on Xelox. Okay? Patient is now getting capecitabine and oxaliplatin. Okay? This patient is now getting oxaliplatin and capecitabine. Okay? The BSA is the same, 2.04. Similar question, what will his oxaliplatin dose be after 2 cycles? Okay, 1 cycle is getting 130 milligrams.
530 milligrams.
Okay, so after 2 cycles, I need to handle 530. Ooh, good. All right, now everybody's capecitabine. His capecitabine dose, and that might be a little bit tricky because I gave a range, right, of 850. Well, you do 850.
You want to see it?
Twice a day. And it's per meter squared, so you have to use this BSA. $34.68, right on point. Did we get it? Okay. All right. Keep in mind now that capecitabine only comes in 500 milligrams. So, how many tablets are you going to dispense? How many tablets will the patient take per day? So he's going to take, you see, 3, 4, 6, 8 total per day. But how are you going to tell him? Because the tablet comes as 500 milligrams. 6, everyone agrees? Anyone thinks differently? You round up. The same rounding principle applies.
7.
So it will be 7. Even though 7 is 3,500 milligrams, but it's very close to 3468. And you won't tell the patient to take it in half, you won't tell them to take a quarter of a pill, you have to take it all, okay? Take it all. All right, so keeping it simple, 3 tablets in the morning, 4 in the evening, and the patient will be good. All right. And that's the end. Any questions, comments, concerns? A lot of information? No? Good pace? Good understanding? All right, you all know how to reach me. Send me an email if you don't understand anything, and I'm happy to support you guys. Wish you all the best.
Thank you.
Have a great lunch and enjoy the afternoon. Bye guys.